Thank you. We are excited to speak to you all today about the Infant-Driven Feeding Program. As you may know, Dr. Brown's Medical acquired IDF last October. We hope this webinar provides insightful information on how hospitals are having great success with the program, but also how we plan to partner with your hospitals to create change in feeding culture in your NICUs. After I give a brief overview of IDF, we have three very experienced therapists here to discuss their hospital's experiences with their program. You will hear from Kelly Phil, Mary Beth Lohman, and Elizabeth Jeanson. I could speak the whole hour on neurodevelopmental care, feeding struggles, and why you need IDF. But if you are here, I'm assuming you already know, or at least are familiar with this, and now you want to know how. We need consistency in our feeding practices. Consistency creates positive outcomes. We know that the traditional feeding model doesn't work. We also know that feeding practices vary from nursery to nursery and even caregiver to caregiver in the same unit. We know that a relationship exists between the consistency and continuity of feeding management practices and improved performance. And in fact, the National Association of Neonatal Therapists in 2013 put out a statement about infant-directed feedings and made this statement. And we know that consistency allows for skill building and predictability. So why IDF as opposed to other programs? Please remember, a tool is just a tool. There are many scales out there, but scales are just scales. IDF is more than a scale. It is an entire program. IDF is a NICU-specific feeding course video training for unit-wide education for your whole entire unit. It is the first and only scalable neonatal feeding courseware created for hospital staff. It provides comprehensive education on the importance of a neurodevelopmental approach to feeding. It isn't just information that talks about feeding. It doesn't talk about just bottle feeding or breastfeeding. It starts way back in the beginning on neurodevelopment and how to provide positive feeding experiences. It also includes permission to use the infant-driven scales in your NICU, including breastfeeding supplementation algorithms. And this is huge. Infant-driven feeding does not just teach about bottle feeding. Breastfeeding is a huge component of IDF. In addition, research supports many benefits for infants, staff, and families. Some of the research that has been provided on IDF shows a decrease in time to full oral feeds and a decrease in length of stay. In addition, there have been reduced hospital costs. Research has shown increased parent and staff satisfaction and confidence, and increased kangaroo care time and increased breastfeeding rates. And when I say increased breastfeeding rates, I mean increased breastfeeding rates with an exclamation point. One of the posters that was presented at Bonn last year, the Brar poster reported that breastfeeding rates at discharge increased from a baseline of about 20% to 62%, quite an improvement. So IDF for your hospitals can have huge success and huge improvements. So how is the IDF program different from other programs? IDF identifies a process for consistent implementation. It includes, as I mentioned, a neurodevelopmental foundation and includes families. It includes breastfeeding and bottle feeding. So not only are all of these clinical skills and clinical applications present in the program, but one of the big parts of IDF, it includes a component on systems change and how to incorporate this into your system and how to change the culture in your NICU. As I mentioned, it also includes use of the scales. And then coming soon, in late fall, which we will discuss a little bit later, unit purchase of IDF will include an implementation program, and we'll go through that a little bit later. But now I'd like to introduce our first guest speaker. Kelly Phil is a senior occupational therapist at Children's Hospital of Pittsburgh, where she worked for over 16 years. Kelly spends the majority of her professional time in the NICU and is driven to improve the developmental and feeding outcomes for infants in the NICU. She's presented on the viscosity of thickened liquids, as well as infant-driven feeding at the National Association of Neonatal Therapists Conference, the Children's Hospital Consortium Network Conference, and at local feeding conferences in the Pittsburgh area. Aligning with her passion for pediatrics, Kelly is also the proud mother of 3. And I just want to thank Kelly for being here today.
I have no relevant disclosures to report. As Lisa mentioned, I work at Children's Hospital of Pittsburgh. Our hospital houses a 55-bed NICU on the 8th floor. Our NICU is a level 4, indicating that we accept medically and surgically complex patients. We have several other NICUs in the Pittsburgh area that do not offer surgical services. We have approximately 1,000 admissions per year, with respiratory distress being the #1 reason for admission. Other common diagnoses addressed include necrotizing enterocolitis, hypoxic ischemic encephalopathy, congenital diaphragmatic hernia, congenital anomalies, seizures, cardiac issues, among other more common preemie complications. We accept all gestational ages, which means we have 22-week micropreemies, as well as newborns born post-term with medical concerns. So I'm going to start with a little story about how this whole idea got started. Once upon a time, in 2015, I attended my first National Association of Neonatal Therapy conference. I was fortunate enough at that conference to already be familiar with the idea of cue-based feeding when I stumbled across the infant-driven feeding table. I stood and chatted with the reps for a bit and picked up a few pamphlets, which got me completely inspired to champion changing the culture of feeding in our NICU. I flew home from Phoenix to Pittsburgh thinking, yes, IDF, that is going to be my quote-unquote before retirement goal, my swan song, a great professional accomplishment. If I do nothing else with my career as an OT, I'm going to implement IDF in my NICU. At the time, I was 35, so I was giving myself roughly 25 to 30 years to accomplish this goal. I got back from the conference all jazzed up and told my colleagues, my manager, and my friends that work in academia that this is what I was going to do before I retired. About 5 months later, my manager informed me that there was a grant opportunity within our hospital system entitled the Frontline Innovation Grant. The idea behind this grant was that if anyone had a project that they believed would improve patient care and patient outcomes, they could apply to get up to $10,000 funding to support the project. She encouraged me to apply, so I began the process of discussing this proposition with the medical director and educators in the NICU. The happy ending to this story is that the medical director was absolutely on board, wrote a letter of support that accompanied my application, and we were awarded the grant in late 2015, which was enough to educate the over 150 nurses and therapy staff that works in our NICU. As with most projects implemented in a large healthcare system, things basically went at snail's pace from that time on. To give you an idea of our timeline, this is an outline of what we accomplished each year starting in 2015 until the present. In late 2015, as I've already described, I discovered IDF and had worked in the NICU long enough to recognize that a change was needed with regards to our approach to feeding. We conducted a review of the evidence available at the time to ensure IDF was supported in the literature. We applied for and were awarded the grant to purchase the web-based IDF module. In 2016, a super user committee was established, which included nurses and therapists working in the NICU. We also formed a NICU feeding task force, which met monthly and included the medical director, another interested neonatologist, the NICU educator, lead nurse practitioners, and occupational and speech therapy representation. During 2016, I was fortunate enough to be assigned a doctoral OT student from the local university who helped with drafting a hospital policy and generating various resources and presentations to prepare us for implementation. Over the course of 3 to 4 months, the web-based IDF module was assigned to about 200 staff members with a requirement of completion by January 2017. During this time, we also created electronic documentation to reflect IDF scores. In March of 2017, we officially implemented IDF in the unit. The first week we worked to generate excitement in the unit with snacks and balloons and ensured therapy staff and super users were identifiable if questions or comments arose. I personally began attending medical rounds twice a week, and a speech therapist also attended twice a week to improve communication between the medical team and bedside staff and ensure appropriate babies were being scored. Our presence was often enough to remind staff about IDF and spur relevant discussion during rounds. Over the course of the remainder of the year, we provided ongoing education and troubleshooting as problems arose. This included roaming refresher courses in the unit and some meetings with nursing staff dedicated to making sure all users were interpreting the scales consistently. Once IDF had been up and running for 6 months, we determined it was time to start looking at our status via structured chart reviews. In 2018, we gathered outcome data over the course of 12 months. Currently, we're working on writing a manuscript to share our outcomes and experience. To give you an idea of our policy and procedure, here's a simplified version of our bottle feeding algorithm. IDF readiness scoring became a new standard of care for nursing staff at this time. We established recommendations on when to initiate readiness scoring and guidelines regarding when to consult the feeding team based on readiness score or quality score trends. And here's our breastfeeding algorithm, which was adapted from the IDF protocol. A lot of time and effort was dedicated over the course of the last 2 to 3 years with regards to discipline-specific and task-specific resources and education, as well as celebrating our accomplishments. We generated a parent handout, computer-sided IDF cheat sheets to be used by the nurse practitioners, and Pocket Pal cheat sheets to be used by nursing staff. With nursing input, we also created and disseminated more specific quality score guidelines. Around Halloween during the first year, we passed out candy bars with IDF reminders and provided brief education during shift change huddles. At our 1-year anniversary, we threw a party to share preliminary outcomes and celebrate everyone's hard work with cake, of course. Now we are nearly 2.5 years post-implementation and have been using IDF long enough to have some outcomes to consider. This is the exciting part. Our quality improvement project was approved by our institution and involved completing chart reviews to look at the following outcomes: time to full oral feeds, length of hospital stay, and postmenstrual age at first oral feeding. We compared a cohort from 2015, which can be labeled as our old model of feeding or a practitioner-driven model, with an IDF cohort gathered between October 2017 and October 2018. Here are the averages of what we found relative to our outcomes studied. You can see our inclusion and exclusion criteria illustrated on this slide. These diagnoses were excluded from this analysis to account for large variations that could be attributed to medical complications. However, a quick point of clarification: in our unit, we do use IDF with these diagnoses. You can see in terms of the outcomes that the average length of stay for the practitioner-driven model versus the IDF model decreased from 42.67 to 37.69. Average time to full oral feeds decreased from 17.57 to 12.65 days. And our postmenstrual age at first oral feeding did not change much between our retrospective group and our IDF group. Here's a summary of previously published literature that looks at the use of cue-based or infant-driven feeding approaches and found a decrease in time to full feeds between 3 and 17 days. We found a decrease in days to full feeds of 4.92 days. Here you can see the comparison of median values, and I'm proud to report a statistically significant p-value with a favorable confidence interval as well. Moving on to considering IDF's effect on length of stay, previously published research has shown a decent number of statistically significant decreases in length of stay, ranging from 1 to 11 days. We found a decrease in length of stay of 4.98 days when comparing IDF with a practitioner-driven model. Again, here are the median values represented, which allow us to calculate our p-value. Our p-value was 0.4129, which was not significant, but certainly can be considered fiscally significant, given that the average cost of a NICU stay per day is usually between $5,000 and $6,000. Considering this, if IDF can decrease length of stay by nearly 5 days for even 1/4 of our annual admissions, we could save nearly $7 million per year. Interestingly, when we looked at the postmenstrual age of the first oral feeding, we saw almost no change. I had anticipated we would potentially see later trends. However, our medical director anticipated the opposite, earlier introduction of oral feeds. We were both wrong. Although we can't exactly explain the lack of change seen here, we know that this gives even more power to our other outcomes, since feeds were initiated around the same time, but full feeds were accomplished sooner, and overall length of stay was decreased. We also realized that this is later than what is indicated in literature, with many infants being prepared to initiate closer to the 34-week gestational mark. But remembering that we are considering more medically and potentially surgically complex of NICU infants, this discrepancy isn't surprising. At this point, IDF is fairly well established and frequently used in our unit. However, we still face some challenges, including how to efficiently and effectively educate new nursing staff and ensure continued competence for all nurses. Fortunately, the NICU is willing to purchase education for another 100 individuals, and we're in the process of designing an annual IDF competency for previously educated nurses. Additionally, some of the other NICUs in the UPMC system have expressed an interest in using IDF, and many have contacted myself or members of the NICU Feeding Task Force to discuss how we might be able to support them in this process. Although it is not yet designed or submitted for approval, I would love to conduct ongoing research on a more long-term basis to determine whether infants fed via IDF have fewer pervasive and persistent feeding problems throughout childhood, because we know this is a risk for our population that we need to be concerned with reducing. Lastly, I'll mention that although we are 2.5 years post-implementation of IDF, we still struggle with the persistence of volume-driven culture practices. At the start of this project, it was necessary to reflect on the culture that surrounded feeding in the NICU because the implementation of IDF was about to challenge the culture. Historically, NICU caregivers fed infants at certain time and frequency based on a physician or practitioner order, often based on gestational age, not readiness cues. The volume-driven or practitioner-driven culture supported the caregiver in doing everything she could do to, quote, get the volume into the infant. The more volume the infant took, the better it reflected on the caregiver. As for stress cues, autonomic instability, or disengagement cues that the infant may have shown, these could be ignored or de-emphasized within a volume-driven model. As we continue to make efforts towards culture change in the NICU, we see that it is sometimes hard to give up old habits and get away from the well-worn path. A lot of times we do things the way we do them because that's the way we've always done them. What's important when changing a culture is to realize that several factors come into play: education, acknowledgement of the former culture, rejection of the former culture, adoption of a new culture, and more education. Culture change takes time and intentional and continuous work to transform the way we think, talk, act, and teach. The goals of an infant-driven feeding culture are to make feeding a safe, nurturing, and functional experience that is individually and developmentally appropriate. In this approach, the infant is an active participant in the feeding, and the infant's cues guide the caregiver. Volume alone is no longer the definition of a successful feeding. Volume matters and quality matters too. Approaching infant feeding in a new way has required blazing a new trail and moving to a practice that makes more sense. Nurses and others in the NICU are currently making this transformation, and as everyone becomes more skilled at use of the infant-driven feeding approach, this will hopefully become the new, well-worn path. Thank you, Lisa and Dr. Browns, for giving me this opportunity to discuss my experience with implementing infant-driven feeding in our NICU. I hope this helps answer questions or inspire some of the audience towards similar ventures.
Thank you, Kelly, for your passion and dedication to this program. I love your story of how you got excited about IDF, and I'm also glad it didn't take you the rest of your career as you originally maybe set out your goal to do. Congratulations. Mary Beth is an occupational therapist practicing in the pediatric and NICU setting since 1981. She has been lucky to have also worked in early intervention, NICU follow-up clinic, community-based massage, and playgroups for graduates. She is NDT trained and also certified in infant massage. She has spent the last 17 years at Summerlin Hospital in Las Vegas, where she had had the privilege of helping to grow her 52-bed NICU from the start. Welcome, Mary Beth.
Thank you, Lisa, and thank you, Dr. Brown, for the invitation to share my NICU's journey through the infant-driven feeding process. I have no relevant financial or non-financial disclosures to make. I want to start with how it all started, why and how we got to using infant-driven feeding as our standard of care at Summerlin NICU. As Lisa mentioned, I have been there through the growth from a small special care unit all the way to a 52-bed unit in a matter of 5 years. And as you can imagine, this included truly growing a lot of personnel to develop the same type of cares. We had recognized early on we needed to teach a lot of developmental care to older nurses who maybe weren't as trained in it, or people from other places that had not participated in it. But we came to realize in around 2015 that our feeding was one of the areas that we really hadn't brought together. Although we had been supported in using the infant-driven feeding model in the early years that Tara Ann and Sue Ludwig put it out, we weren't doing it in a formal manner. We also realized there were many aspects of the care that we just weren't ready for. So we kind of sat back and talked about all the things we would like to see happen and came up with a program, some thoughts about promoting oral feeding beginning to end. And in this concept, we wanted to make sure we got everybody on the same page about all aspects of practice. So we wrote for a grant, which we received from a formula company, and we planned for a slow 12-month rollout on everything and anything that had to do with feeding. We started focusing people on the history and the older feeding practices as well as the new, so that people would feel engaged from what they knew and where we were going. We also decided to just bombard with written resources, bulletin boards, emails, and even an education cart where we had hands-on activities. And this is really looking at the fact that everybody learns things in a different way. What you may give someone in a written form may be much better learned in a hands-on form. First month, we started things like early conversations with parents, talked about milk production, skin to skin, early cares and touch, and even identifying infant stress and engagement. And the concept here was, what are the first things staff should be doing with people, and are we actually all doing it? We recognized everybody had a different style, but we were trying to set the pace of what was the standard in our unit, what we expected everybody to do with every patient. So as nurses took over one from another on different shifts, everything was going to carry through smoothly. So this is an example of our first month. We had laid out plans and carried through with plans. March, we started doing kangaroo holding on ventilators. We started doing things with children with respiratory problems, bottles, nipples, all the things you can imagine that go with feeding. And what we did was we just each month would add new things, but also kind of go back and test new things. One of the ways we kind of followed how we were doing with this project was we would have one-to-one conversations with staff, get that feedback from them directly. On our little education cart, which by the way is actually a crash cart that we modified, we actually had quizzes on there. We would have cards and games and Wheel of Fortune and all kinds of things, but we still were testing their knowledge and what they had retained. We had some video tests where we would show, something happening with feeding or kangaroo holding and get the feedback from them, what they thought was going on. We would even role play. What we found is the more we did this, the more people would engage and the more the conversation would just escalate. And it was a great way of engaging everybody. We did do chart audits, although we learned chart audits are only as good as the people who chart. And that can't always be counted on. And one of the biggest things we did was offer small rewards. And believe me, the night shift really looked forward to us coming by at 6:30 in the morning with chocolates and gum. Then we had divine intervention drop out of the sky. Someone from Universal Health Services authorized the infant-driven feeding program modules for all of Universal Health System. It still is an unknown administrator, but I thank them. But in addition, my administration picked it up and offered that paid time for all nursing staff, including postpartum, labor and delivery, antepartum, anybody associated with feeding infants. And they were paid to take the program. And as well, they were also compensated for following up with us when we did a skills and drills review and the formal rollout. In addition, my medical team also put together what they're calling their infant-driven rollout, which was followed by the medical director and then presented to the staff. Not all medical staff did participate, and so there was a slower curve of learning for them to have that communication with the nursing staff and the therapists. We did continue to offer other education opportunities, and specifically, I had identified through all our conversation that we needed more work on recognizing subtle behaviors, on sitting on your hands and coaching parents, on really adapting a position for the optimal feeding. And of course, I always battle the nipple choice controversies and discussions. And just plain communicating, staff to staff handoff. Sometimes they're in a hurry at their time of changing nurses, but we really wanted them to get more specific so that they could help each other. Again, we did those one-to-one audits. We offered skills and drills. We even offered at least 2 major national or international speakers coming to the hospital to do some speaking and some further education. And then we also continued with chart audits. We have established ongoing training with new staff. We try to do one-to-one training and then direct follow-up with a therapist so that they've got a comfortable person they can ask questions or identify to see how their baby's doing. It isn't the optimal system, and we would really love to see further utilizing the infant-driven feeding program itself and allowing everybody to take the full program on a regular basis. We do include each year some aspect of the infant-driven feeding model in every single skills and drills. Ultimately, there always comes up questions about how to mark bradycardy and tachypnea episodes, things like that, controversies on, where does stridor fall in. So these are things we try to identify and help bring everybody to a common ground on. We have also instituted feeding rounds, which have really proven beneficial for the entire team. And these consist of twice a week meeting with the medical team and therapists, and then we go to the bedside of a few babies to talk with the nurse and develop a more specific feeding plan. This is really fostered by the infant-driven feeding because we've, again, got that common language. Our clear benefit is that, as I just said, infant-driven feeding has brought us a very common language. Everyone uses those same words over and over again and use it with the family as well. People seem to be more compelled to talk about their feeding and in a better way. Instead of the baby's wimpy or pokey or they did fine, we've got more specifics with the scales that we use. Further, I think concerns really seem to be picked up earlier. It seems that nurses are noticing, maybe a baby isn't as comfortable with that feeding, or they're getting uncomfortable halfway, or they're showing facial behaviors, or changing postures, or changing the way that they're eating, and we're getting more specific to that individual baby. What else we have learned is that people actually don't always ask questions. Sometimes they're just satisfied to, if something happened the shift before, well, that's how the baby is. And maybe they're seeing something, but they don't have time. Maybe they're afraid to bring anything up. So that's why conversation from those of us who are following through helps. They also don't always see it the same way. An example being a baby who suddenly has stridor, when in fact they've actually had stridor all along, but it was seen as just something the baby does. Behaviors are particularly the thing that we see differently and we have to all talk about. And finally, we have learned that all of the team needs the ongoing training. We did neglect to make plans for ongoing training of our medical team, and that's unfortunate because for those new people who come in, they haven't had as much training and understanding, and therefore the communication you can see falling off a bit. The single most beneficial thing I can say is that you can do based on all this that you have learned from infant-driven feeding, is that you can learn to sit and talk with your staff, because you do have more common things, and you do have gain more respect for observations that you make. And I think the time we spend sitting, just observing a baby or asking a nurse how that night shift went and how the baby did, is really brings the plan together in a much stronger way. All right, thank you, Lisa.
Thank you, Mary Beth, for sharing your hospital story and providing us with much encouragement for our unit. I'd like to now introduce our third and final speaker before we summarize the IDF program. Elizabeth Jeanson has been hanging with the babies for the past 25 years. She loves certifications and education and has acquired as much as she can afford on her therapist salary. She has presented at national conferences and always learns at these national conferences. She works with a highly experienced team at Sanford Children's Hospital in the 72-bed Level 4 NICU. She led the IDF implementation team to a very successful culture change and improved outcomes for babies. Please welcome Elizabeth Jeanson.
Thank you, Lisa, and thank you, Dr. Brown's Medical, for inviting me to speak today about our experience at Sanford. Sanford Children's Hospital is a large regional hospital with a 72-bed Level 4 NICU. We care for infants from 22 weeks to term with a variety of conditions, including those with surgical needs. Sanford employs over 200 nurses and 50 float staff that work in the neonatal intensive care unit. Currently, there are 22 nurse practitioners and 10 neonatologists. Sanford Children's began the process of adopting infant-driven cue-based feeding in 2017. To say it was a perfect storm of coincidence and good fortune would be an understatement. I have nothing to disclose. Here at Sanford, the time frame from introduction of the concept to full implementation of infant-driven feeding was about 18 months. It began one typical day in the case manager's office. Kala, our formula rep, came into the office to check on our supplies and casually greet the team. Oddly, she asked me if there was any feeding-related content that I thought the unit could use more information about. I had been asking about IDF for the past 3 years with interest from the administration, but no action. Perhaps Kayla would be able to help me on this task. I asked if her company could sponsor a one-day or half-day speaker to come and talk about infant-driven feeding. She said she would look into it. A few weeks later, she called to ask if our unit would be interested in a day-long conference with some speakers on IDF, and I assured her that nurses and therapy team would be interested. A few weeks went past, and Kayla came to visit the unit again. This time, she spoke with the administration to ask about sending nurses and administrators to an infant-driven feeding conference. The NICU director came directly to my office to ask if anyone had heard of this Sue Ludwig and Kara Ann Waitsman, and if infant-driven cue-based feeding was something we should look into. Everyone in the office assured her that Ludwig and Waitsman were indeed the experts on infant-driven feeding, and we would be lucky to have them speaking to us. It took some convincing, but we were able to get 15 staff members, including the NICU administration, to attend this one-day course in Minneapolis, about 4 hours away from where our hospital is located. Goal 1 reached, administration buy-in. Next coincidence and good fortune that occurred was at the Quality Fair in October of 17. I had a presentation on head shaping in the NICU with the good fortune of the chief nursing officer as my judge. Normally, it would not be a good fortune to have the CNO judging your quality improvement poster, but it gave me the opportunity to use my IDF elevator speech with someone who had the power to make it actually happen. In my 2 minutes, I was able to explain the process, the potential, and the cost. I simply said, the cost of care for infants born prematurely can be affected by many aspects of care. One aspect of care is how babies gain the efficiency and coordination for feeding. Feeding difficulties can lengthen stay and increase costs. The IDF model improves feeding efficiency by carefully monitoring and effectively intervening during feeding at the breast or the bottle. IDF has been shown to improve feeding outcomes while at the same time reducing the length of stay and cost of care. Although there is financial investment to initiate IDF, the payoff can be seen within 1 year of implementation and continues to produce returns long after the initial investment is completed. It will be important for you to have an elevator speech for staff nurses as well as for parents. Surprisingly, the CNO thought she had some funds from the foundation that had been earmarked for another project. She was going to crunch some numbers and talk to the NICU administration. It seemed to her like the opportunity to improve care and reduce costs at the same time. Goal 2, reached. Funding. The Sanford process of implementing infant-driven feeding was about an 18-month process, as I said before. Our first year was spent in getting administration buy-in and finding funding. That took at least 6 months. An interdisciplinary team was formed, and the committee worked following the 4 disciplines of execution principles to get the work done. The first principle is that you have to identify a wildly important goal. Our goal was to reduce cost of NICU care by 10% by January of 2019. The second principle is to identify lag and lead measures. Lag measures are simply things that affect your goal that you don't have any control over, such as diagnosis, equipment availability, gestational age. Lead measures are those things that you can have control over, and introducing the IDF feeding protocol was exactly that. According to the 4 disciplines, it was important to have a visible scorecard that tracked completion towards the goal. For us, that was education completion by our staff, the percent of orders written for IDF. We created a cadence of change, also an important factor in the 4 disciplines, with weekly meetings with accountability for all participants. It is vital to have an administrator, a medical doctor, a neonatal nurse practitioner on your committee, not to mention nurses who are both cheerleaders and naysayers. Our committee had about 14 members. You need a strong leader who is capable of using the 4 disciplines to keep the cats on track. The committee met weekly for the first 6 months and then monthly for the second 6 months. The first 6 months of active committee work was used to build excitement for the upcoming change. Building excitement among staff was crucial to our success. During this time, we also completed our pre-change quality measures, which included a pre-staff survey, length of stay information, days to ad-lib demand, number of G-tubes provided, number of NG tubes used, initiation of first breast or bottle feeding, and percent of breastfeeding at discharge. Changes to the electronic medical record took several months with many revisions. The second 6 months of committee work was focused on staff education. We used a wide variety of tools, including potty ponders, bulletin boards, lounge read-in signs, huddle reviews, department meetings with presentations of each part of IDF, along with the kickoff Skype presentation by Kara Ann Waitsman herself. There wasn't a place that you could sit or relax that didn't include some information about IDF. We saturated the staff with information. We even had an anonymous question and concern box. All of this education led up to the December of 2017 release of the formal education. By January of 2018, we had 100% of staff completion. Staff had 2 months to complete, and by using our scorecard that showed how much staff was completing it each week, it facilitated quick completion of the training. We had 2 neonatologists who completed the long training and 8 who watched the short MD introductory training. All of the nurse practitioners were trained with the long training, and every speech, OT, and PT that worked in or floated to the unit was trained. The committee created tangibles to help the staff retain what they had learned. These included a family feeding plan card. This card hung on the cabinet inside the patient room for everyone to see, and it indicated what the family's goal for feeding was. There was a nurse resource sheet kept in the nurse reference binder in every room. We had a laminated MD NNP resource sheet, and which included the order set hooked to the portable computers they used for medical rounding. Actually, everything was laminated. There were copies of all of the information stored on the NICU internet for easy access. Copies of the feeding flow sheet were available in the lounge. A flip book for nurses to use for parent education was made, and every room had one that included readiness cues, caregiver assistance during a feeding, cues given for babies, and interventions to help babies bottle or breastfeed better. It also included our breastfeeding time algorithm. These continue to be used today for parent education. Parents will even grab them for reminders for themselves. Finally, a parent handout was created that explained the process and cues and the assistance babies might need. This is reviewed with every patient prior to starting the program. Our speech therapist created a PowerPoint presentation that reviews the program and discusses nipple selection, caregiver support, the swallowing mechanism, and typical roadblocks to easy feeding. This is provided by order for 75% of our admissions and 100% of premature babies less than 34 weeks. How do we keep the staff motivated and interested during the whole year it took to get everyone on board? Celebration. One aspect of the 4 disciplines of execution is that you can't overlook celebrating success. We kept a visual indicator, like a thermometer, to visually depict how many staff had completed the training. We gave out awards for the first NICU staff completed, the first float staff completed. We had a party with treats in the lounge for kickoff. We had another one at Go Live. We had a 1-year anniversary celebration where we reviewed the improvements in days to first breast or bottle feed and the reduction of NG tubes used. Parent presence at the bedside increased during implementation and was quickly noticed by the staff and reported to us by our volunteer cuddlers. The committee itself also had many thanks for being accountable celebrations and acknowledgments. Keeping the celebrations happening as each milestone occurred magnified acceptance by the staff, even the naysayers. During the past year with IDF up and running, we've had to do some policing. The committee built some safeguards into the plan with shift change huddle notes where the outgoing nurse would describe the nipple used, the average duration of the feeding, the typical cues a baby may have exhibited, and interventions used to help the baby be more successful. Every staff member was empowered to interject a quick, isn't that baby supposed to be elevated sideline as they walked by a room and a baby was being fed in an alternate position. The hardest area to police was the copy forward option in the medical record, which could be used for quality of feeding and caregiver assistance. We asked IT to intervene, and it is no longer possible to copy forward any of the feeding flow sheet. We also had IT eliminate the old order feeding set. If an MD or NNP wanted something other than IDF, they had to type it in. Each week at interdisciplinary team, progress and roadblocks to feeding were reviewed. Infant-driven feeding is now part of our new staff orientation. We added another full-time speech therapist to the team. Our speech therapist worked with the supply chain management to make sure our slowest flow nipples were available on the cart for staff to select. Finally, the speech therapy team reviews every baby's feeding performance daily and follows up on any triggers noted. The policing will never end, as there's staff turnover and staff sometimes get bombarded with too high of acuity, but our measures so far have been very effective. Key points to our implementation were that if you wanted to change the culture, everyone that works in the culture must be involved. Changing mindsets takes concentration and saturation of information. You must start with administrative cooperation, do your entire NICU, and do it all at the same time. A strong committee leadership is a must. The leader must be equal parts principal and secretary. Celebrate every success visibly so that the staff can see that their actions are making the difference. And finally, don't start any other new initiatives at the same time you're starting IDF. Here at Stanford, we've had excellent outcomes since we implemented IDF. 100% of our staff are trained. We've incorporated the video education as part of new staff orientation. We've decreased NG use. We've decreased the cost of care through NG use and extension sets. We've increased nurse satisfaction. We've increased the number of feeds by each parent, and we've decreased our overall length of stay. Thank you for allowing me to present today what happened at Stanford. We continue to use IDF as our primary feeding order set.
Thank you, Elizabeth, for you and your hospital's enthusiasm and commitment to infant-driven feeding. Great job. I hope you can see, after hearing from all of our speakers, how this program can work in your hospital. IDF is real, IDF is possible, and IDF creates change. Now that you've heard from our speakers, I wanted to spend just a few minutes discussing our future implementation program that will begin to roll out later this year. For hospitals that purchase IDF, we will provide an implementation program as well as monthly support calls with our clinical liaisons. The implementation program will include a packet, if you will, of materials to help support you through the program. One of these materials will be a checklist to help guide you through the steps in the process. It has been divided into phases along the way. For example, phase 1 is the investigation and purchase phase. Phase 2, planning and implementation. Phase 3, core team execution. Phase 4 is the plan staff kickoff for educational modules. And we have a lot of suggestions to help provide you with ideas for fun examples and activities for the week. One of the things about, as Elizabeth mentioned, is to make it fun and to be consistent and to saturate, but to really celebrate success. So we want to help you be able to do this and give you some creative ideas. Phase 5 is go live, beginning the IDF protocol and scoring, and phase 6 is post-implementation so that you can have carryover and success in the long run. As you notice, after listening to some of the presenters, some of their processes took years to do. So we're hoping that by having an implementation program, each and every hospital won't have to do it on their own and reinvent the wheel, but we'll have some guidelines on how to go about this process. At the bottom of your screen, you can see a small example of items that are on the checklist. Other support materials you will receive will be parent handouts, bedside nursing reference cards, a kickoff package that includes stickers, a hospital poster, and other fun things, and then as well, suggestions for a QI project. Again, we want to help you along the way to provide support and materials for your hospital. A quick note, I realized that at the beginning, I was reading a slide that said NAN, N-A-N-N, but I mistakenly said NANT, National Association of Neonatal Therapists, and that reference was indeed NAN, the National Association of Neonatal Nurses, so I apologize for that. Okay, that wraps up our presentation for today. We will now take questions for our speakers, but if you have any questions regarding the program, please reach out to us at Dr. Brown's Medical or Infant Driven Feeding at the emails and numbers on your screen.
Okay, thank you everybody for who is still able to hang on here. I apologize about the technical difficulties. Mary Beth, we have a question that's actually directed towards you. One of the questions was, you were saying that at first you just had the scales and it wasn't working too well until your whole unit went through the online modules. Why was that different?
Well, I think the online modules really provide the depth of education. I mean, you know how you teach something and yeah, I get it, I know, but those online modules were so thorough and well done that they only reinforced everything we'd ever tried to feed in a much more formal manner. And everybody heard the same thing.
Okay.
So you can't do it on, you can do so much on your own, but I really feel the program hold it together with credibility beyond, you know how you can't preach to your own choir sometimes.
Right. Okay, so I have one that's kind of directed at all three speakers. Were there any technical difficulties with the course that you would like to address? Was there anything that jumped out at you that you think would have made the implementation a little bit smoother?
I could answer that. We really didn't have any technical difficulties in terms of technology or being able to access the online module. Once our technology department at our hospital system was able to work with HealthStream to get it going.
Okay, perfect.
I would agree. We had no problems whatsoever. It was really a nice, smooth, we just needed to get our nurses to sit for a few hours.
Gotcha. Okay, and then the last question I'm going to go ahead and address, and this is kind of addressed towards all three speakers, anybody that wants to jump out. How did you convince your neonatologist to get on board?
I guess I can speak to that at that time we had people who really were willing to listen to the struggle we were having. We would have these discussions and not have the same language, and we really shared some of this information. It was pretty obvious that here's how we talk to each other.
Great answer. Perfect.
Yeah, I would also say, this is Kelly. In my presentation, we did have those summaries of previously completed research to show that infant-driven feeding models decrease time to full feeds and decrease overall length of stay. So I feel like when it came to talking to the neonatologists, evidence always speaks volumes. So that was helpful to be able to promote the program and the change.
Fantastic.
I agree. This is Elizabeth, and I would say I agree with what everyone has said so far. We also had a few neonatologists who came to our department, new to our department, who were using infant-driven feeding where they came from, and they were immediate advocates, which really helped the process.
Well, fantastic. Thank you, ladies, for your answer. Kelly, Mary Beth, Elizabeth, we really appreciate you being with us today to present this webinar. I'm showing 1 o'clock here, so we're going to go ahead and wrap it up. We don't want to keep anybody too much longer than what we had scheduled for. To the questions that we were not able to address today due to the technical difficulties, again, I apologize that Lisa wasn't able to get on and speak towards these questions. But we will be putting answers to these questions, and when the webinar goes up on our website, we will be including those Q&As in a PDF format so that you'll still be able to review the information. So I just want to take a moment and thank everybody for logging on to Dr. Brown's IDF Infant-Driven Feeding Program today, webinar today. And we look forward to seeing you at any future at our future webinars. So everybody have a wonderful week. Thank you.